Hello, my name is Dr. Stuart Weinstein. I'm the editor-in-chief of PM&R, the Purple Journal. I'm joined today by Dr. Janna Freely, who's the incoming editor-in-chief, and Dr. Heidi Prather, who is the lead author of this year's Editor's Choice Best Original Research paper. So welcome to both of you.
Thank you.
We're here today, Heidi, to talk a little about your paper and have you give us some insight and maybe some clinical pearls as well. But before we talk about your paper, I'm just curious if you can give us some background about your interest in hip pain. You know, several years ago when physiatrists were really most interested in taking care of back pain, you seemed to step out and go into the domain of orthopedic surgeons. So give us some background about how you got interested in hips.
So hip pain to me was just an extension of any type of musculoskeletal care, but particularly back and posterior pelvic girdle pain. And at the time I was being asked, and I had a big interest in posterior pelvic girdle pain. It was around the time when Andre Vleming was first starting the World Congress, and I was reading all of his papers, and it became obvious to me that the missing link between back, when we talk about lumbopelvic pain, is back, pelvis, and hip. At the same time that that's happening, I've joined practice at Washington University School of Medicine, where unfortunately we don't have a department of orthopedics, we don't have a department of physical medicine and rehabilitation, so I joined the Department of Orthopedic Surgery. And a gentleman by the name of John Clohessy was starting a young adult hip group. And that group was dedicated towards clinical and research practices for people with hip deformity. And this is right at the very beginning when arthroscopy of the hip was starting to hit hard in the United States. So I've had this really fortunate adventure, I would say, where I've gotten to see something we didn't know much about evolve, kind of watch practice, everybody kind of does one thing, and now they're sorting it out like we needed subgroup populations of patients with hip problems. And you see that the literature really falling in that way, and I've gotten to be right in the middle of it. I was fortunate, I bring up Dr. Clohessy because he's now the main person who's running a registry for all hip preservation in the United States. And so I've really had this very global sense of the disorder. That led into him sharing data with me when I asked him, can I look at all your patients who have had hip scopes? How many of them have posterior pelvic girdle pain, which turned into my first publication in PM&R when we were a brand new journal. So it's kind of come full circle.
Interesting. So the award this year is for the paper that you were the lead author on, called Anxiety and Insomnia in Young and Middle-Aged Adult Hip Pain Patients with and Without Femoroacetabular Impingement and Developmental Hip Dysplasia. So maybe you can tell us the origin of this study and what was your main research question?
Well, the origin has a great story. I'm sitting in the back of a meeting on spine, and there's a presenter from Bob Gatchell's lab, and Dr. Gatchell is a prolific researcher in the world of workers' comp. And I was sitting in the back of the room with Monica Rowe, who's at the Ability Lab, and we were having a conversation about our hip patients while we're listening to this gentleman present about the burden, external burdens on folks with workers' comp injuries related to the back. And we're sharing in common that no two patients coming in with a hip problem looked alike, and when the behavioral issues were involved, those are the people that were actually coming in to see us with chronic pain-like issues. We're listening to his paper, having this conversation. I said we should do what they're talking about in hips, and that's what we did.
So let's talk a little bit about your study. You had, I believe, 50 patients and 50 controls. It seemed that the average duration of pain in these patients was about 3 years, so they clearly fit the chronic pain model. Was there something unique about the patient, the young adult with hip deformity, that would lead them to develop a chronic pain syndrome with anxiety and insomnia?
Right. I think a lot of things could contribute. So one, we picked a population under the age of 40 because we were trying to exclude those with osteoarthritis, because that's kind of a different group. It's a very easy diagnosis on x-ray when you have osteoarthritis of the hip. So yeah, a good portion of these people hadn't seen somebody or had seen one or two people prior to seeing us. It was kind of a mix. And the reason we did that was because we were seeing people with hip deformity that were having extra issues with pain processing and behavioral. One, because they'd had the pain so long. Two, some of them hadn't been diagnosed. Or three, some of them were told other misdiagnoses. And it kind of just perpetuated, I got to live with this, but no one knows what's wrong with me. And that kind of escalates things over time. And we know just the longer people have pain, these other issues that people may have with processing pain can develop. And we know then if you're not sleeping, we know that relates to having more pain, more anxiety, more other chronic illnesses, obesity, diabetes, cardiovascular disease. So it's kind of this merge of confluence. The reason we really wanted to do this is that this is a young population. And what we were noticing in both of our different areas of practice in the country was that we're now seeing this evolution of chronic pain syndromes in very young people. You know, a 19-year-old who's been walking around playing soccer for 3 years and doesn't understand why I'm having such a hard time playing college soccer, and I can't sleep and I can't sit in class without pain, and oh yeah, by the way, I limp for 5 days after a game. It's striking to us that was happening.
You mentioned the misdiagnoses, and certainly in our experience dealing with chronic back problems, that's really a key factor in setting people down a pathway of chronic pain syndrome. In your experience with these patients, how much did you have to undo what they had been told?
Yeah, probably a lot, or going into the specifics of why you have this and why do you have back pain maybe associated with your hip pain, because we know those two things correlate with each other. At the time specifically, I don't think it's as rampant now, but at that time, it was also when everybody was getting diagnosed with a labral tear, but no one was really expanding into why they may be at risk for a labral tear, which is all the different types of deformity they are. And at our practice, again, because I've been so fortunate to work in this very intense hip preservation world, we look at it very globally. And right now the literature is kind of showing you people have FAI and they have different two types, or they have dysplasia, or they have a labral tear maybe with or without deformity. Probably the people with labral tear without deformity are very small, and probably we're going to evolve into the biggest group of people with hip deformity is actually mixed. And that's going to come in the literature. And it's really confusing because we're realizing we can't measure things just off x-ray. So we used x-ray because it was cheap, easy, and obviously the first line of defense to figure out what's going on. But yeah, over time, I've really seen that happen. So I'd say today, even after this thing has been published, I think we're more into the world of, we're starting to really dive into what structural deformity is. And for those of us in PM&R, this is a real opportunity because we know form and structure have to go together. So how you move becomes very important. Is that a part of why two people with the same looking hip deformity have problems? One moves differently than the other. Does the cognitive part impair the way you move? And so I think that's going to be the next layer of investigation.
Oh, it's very interesting.
Yeah.
I know there were, Janna had some questions about some of the methodology of your paper, so.
Yeah. Well, first of all, congratulations on a very well done and important study. So that's first off. And then I wanted to ask you, your study was designed as a cross-sectional study, and so with that type of design, you can determine associations between things, so insomnia and anxiety and hip pain, but not cause and effect. So what kind of considerations did you take when designing the study to try to tease that out, which came first?
Correct. So I don't think we can say that, and based on the way this study is designed, you can't. We used the asymptomatic and gender matched controls just so we could show that here's where the hip pain patients were and here's where a population looks just like them are. And again, I'm not showing cause and effect, but definitely that there was a difference in the group that had hip pain. And then we asked the people that had hip pain if they felt like their symptom of insomnia had gotten worse, and 85% of them said it had since they had developed hip pain. And the population that answered prior to my hip pain, again, there's going to be a bias of participant recall, they were still in that realm of what's considered normal for the insomnia, or even occult insomnia based on the scale we used. So they kind of went from answering in that normal range to 85% saying it was worse. So there's probably a relationship is all we really want to say.
And is that consistent with your clinical practice as well?
Oh, absolutely, absolutely. But I think the insomnia scale, what's so nice about it, one, it's 7 questions if anyone wants to use it, so you can get through it. And 2, it picks up subgroups, and our biggest subgroup was occult to mild. And that's where you can make, that's when you can turn the ship around. When they're in the severe end, you may end up with a sleep lab because there may be other external effects with it. But I imagine a good number of the patients that we are addressing sleep with kind of fit in that category. Mm-hmm. And there's a big opportunity to turn that around. It's modifiable.
So you measured insomnia, you measured anxiety. You didn't specifically measure depression, but what's your sense of your patient population and how depression fit into the overall picture?
Well, I can speak to that now of unpublished data because in the past 3 years, our university's been collecting PROMIS scores, so patient-reported outcome measures, and because of my background, I really pushed my department to not measure just depression but anxiety, and it turned a light bulb on for the entire department. They're now publishing papers on the difference in that. And I think the literature regarding depression has evolved. Obviously, it's very important, but the literature is showing that patients with depression can change as much as people without depression. People with anxiety are the ones that really hang up and can't make the change. So the literature is true in saying people that are depressed don't do as well as people who aren't depressed, but their ability to change is the same. They just started at a lower state. So we've actually looked at that in the population. This is spoiler alert. We've looked at that in a population, hopefully you're going to see it soon, of looking at comparing different specialties within orthopedics. And so if you take everybody in the department, and we're about 75 practitioners now, and you compare the spine-related folks to all else, they're more impaired behaviorally, function, depression, anxiety, and pain interference compared to all others. If you take non-operative people and operative people, they're about the same. If you take just physiatry and operative, they're different. So we are seeing this population, and we all know it. And thank goodness we have some core training in it.
So clearly it comes back to the messaging that we give to patients. It's such a critical role in helping people recover. Clearly musculoskeletal pain is very common in all of our practices. Do you have a sense of a different risk of developing chronic pain syndrome in a patient with hip pain versus, say, shoulder pain? And if so, what do you attribute that to?
Well, maybe what your first question was to me, which is the problem with the diagnosis. So a shoulder, we know quite a bit of literature about. It's been around for longer than the 15 to 20 years people have been scoping hips. They've been scoping shoulders. And I say that, the surgical piece, because you can extrapolate what we see clinically up until the point of surgery, and surgery is that gold standard of what structurally was happening. You can palpate a shoulder easily. You can, if there's an effusion, if you can't palpate the effusion, you can see it easily on imaging. Even ultrasound picks up glenohumeral effusions easily. Hip's a different story. You can't get your hand all the way around it. You definitely can't feel an effusion. You move it, and you're moving a couple other things, the back, maybe the pelvis, sometimes the knee impacts that. There's a bit of confusion and distribution. If you look up the literature on how it's innervated and the sensation of the hip, it's all the map. People still can't agree on is the anterior capsule L1 to L3 and the posterior capsule 3 to 5. As far as innervation, that's still a mystery. So people come in with kind of all kinds of distributions of pain. So I think a lot of people wander around with it thinking they have a hip flexor strain or a hamstring strain or my SI's popped out. And really, if we'd understood that the mechanics of how their hip is structurally fitting into the socket and how that affects their movement earlier on, we would have more information to give the patient, and they wouldn't wander in with 3 years of pain being 18 years old.
And certainly the hip is loaded different than the shoulder in day-to-day functional life. How confident was your team in your study that diagnosing hip pain was really hip pain and not something else?
So in our study, in the way we designed it was we didn't want to take all comers in with hip pain because we really wanted to measure the x-ray to say, you know, is there a deformity here? Is there arthritis here we didn't know about? We didn't know that. We assumed that, but we didn't know that. And we wanted a bar of that we, as a clinician, thought there was a likelihood they had intra-articular pain. And so we designed that based on weight-bearing status, do you have pain problems with weight-bearing, and then positive provocative tests, which we know are not specific or sensitive in and of themselves, but probably the best we have without doing other invasive tests. In patients who don't do well with hip pain in our practice that we think have an intra-articular disorder and have had the right appropriate treatment, kind of what we put them through is a diagnostic injection next, which is just anesthetic, and if they get relief with their symptom, both provocative and throughout the day of their normal activities, that's when we proceed then to further imaging.
So you indicated that you work in an orthopedic department, obviously work with a lot of orthopedic surgeons. How have the results of this study changed your relationship with your surgeons, and have they embraced a biopsychosocial model of dealing with chronic pain?
Yeah. So I can tell you there's a gentleman by the name of Dr. Kelly in our practice who does spinal deformity, and he heard me give a talk about hip-spine connection, and he does primarily deformity, so kind of a different, but he took away from that as I need to start asking that question more. I really should look at my PROMIS score, and he calls me a month later, Heidi, all of my patients have this. I'm like, yeah, you're awake. Yeah. It was great. I mean, it was this like pivotal moment for us, so he's now published papers with PROMIS on that. I think the big problem, I think sometimes is that you can it's a little bit of opening Pandora's box, that we don't feel armed well enough. That if we do diagnose some of these disorders, like some people really do need, psych versus social work versus coaching, whatever that realm they need on the behavioral health side, and there are not enough practitioners out there to fit the need.
Yeah, well, I think the whole paradigm of treatment needs to change,
Correct.
Not just for hip pain, but
Yeah.
for a lot of
Right.
the pain problems that we see. Janna, final questions?
So what's the next step? You've alluded to a number of different potential studies that could come from this and areas that you would like to understand better given your findings of this study.
Yeah, so I would say what we've been doing now is, again, we do a lot of things looking at associations because that's what we have available to us. So that's my pitch for anybody who can do research in a clinical practice if you design it well, because we don't have a big lab and I don't have a ton of research assistants. I've got some really great residents who will look at a lot of charts or prospectively help us enroll people. But I think our next steps are we're really going down the road of specific diagnosis in subgroups of populations and the association of behavioral health issues. And then if you intervene on that, can that change not only how they feel, but does it change the way they move? So I've been fortunate enough to work with Linda Van Dillen, who is a physical therapy doctorate and PhD, who's been funded in low back pain and hip limb movement for about 20 years. And we've evolved into a grant that we've got out there, hopefully coming back soon, looking at the whole evolution of people that come in with back pain, assessing their hips, watching what happens to them over time, measuring function, movement, and then the cognitive behavioral things we've just talked about, and seeing where those go over time. Our retrospective work together has shown that people that end up with hip and spine disorders don't do as well from a back pain or a hip pain standpoint. We've done that in post-arthroplasty patients, and then we were fortunate enough to publish one this past year in a population of just general low back pain patients. So now we're going to subgroup those into people under 40 and over 40, because there's a big difference there. Some of the things we've run into, which is what you alluded to, is that we know these associations happen, but we don't know why. And I think that's where pairing with somebody like Linda and her PhD candidates in looking at the actual movement and what is it about the hip movement that's impairing people not only just with hip pain but with their back is really where I think we'll really learn some things, and hopefully there'll be a great trickle-down effect for the clinician.
Well, Heidi, from both of us, congratulations on winning this award, and thank you for your contributions to the field.